All right, let's start with myocardial action potential. What do we have? In myocardial action potential, we have it starts from phase 0, goes to phase 1, 2, 3, and 4. Right? Simple. Phase 0 is right here. Then you have phase 1, 2, 3, and the fourth phase. So let's talk of each one of them. Let's see what they are. So, phase 0, it is a rapid upstroke and depolarization, right? So let's just draw it here. It's a rapid upstroke and the cell is depolarizing from negative 85 is going towards in a positivity above 0. It's going towards positivity, so it's going to be depolarizing, right? And it is done by voltage gated sodium channel high yield. It is done by sodium channels. So what do we have here? We just have, if you look at the lower diagram, we have the inward flux of sodium. Looking at here, we have influx. Oh, actually, let's just write over there. Influx would be, let's say, this arrow of sodium. So influx of sodium will cause the rapid depolarization, upstroke and rapid depolarization due to the voltage-gated calcium channel being open. Phase 1 now. Let's talk about phase 1. So we already depolarized. We are here now, right? So in phase 1, and this is specifically to the myocardial action potential. That's very high yield. What is myocardial action potential? We're talking about the muscle itself. For example, all of the atria, all of the ventricle, the myocytes, the Purkinjes, even high yield is this. It is also Purkinjes which go through this action potential, and bundle of his, and Purkinje. They also go through the same action potential because the other ones, which is right here, this pacemaker action potential is just the SNAV node. So all the rest is this myocardial action potential. Now, some other ways that you will hear about this is they will call it fast response action potential. So if this is a fast response action potential, this must be the slow response action potential. And we will see how that is. But just the terminologies here. Okay, so let's look at, we did look at the first one. It is the inward of sodium that caused the depolarization. Now, with the phase 1, what's happening is you have initial depolarization. My bad, initial repolarization. If you look, let's zoom in, there's a repolarization. This is known as initial repolarization. And that is due to the fact that you're inactivating the voltage gated sodium channels, the ones that you activated in this top phase 0. Now you're inactivating that. On top of that, you're also opening your potassium channels. So voltage gated potassium channels begin to open. So when the potassium comes in, you're going into repolarization. And how do we see repolarization? So if this is if this is your action potential here, it just goes down. Going down is the repolarization. Going up towards the positivity is depolarization. Going towards negativity is going to be repolarization. And so let's also write down why that happened. That happened because at your level of phase 1, you have inward influx, actually outflux. What is it? Outflux of the potassium channel, potassium. So if you look here, what is this? This is outflux of potassium. This is myocyte, right? Coming in is the sodium, going out is potassium. When you stop the sodium channel and when you activate the potassium channel in which the potassium goes out, you go into phase 1, which is called as repolarization. That's phase 1. Now let's talk about phase 2. Phase 2 is the plateau, as the name suggests, 2 plateau, which is calcium influx through the voltage gated calcium channel balances with the efflux. Calcium influx triggers the calcium release from sarcoplasmic reticulum and myocyte contraction, which is excitation contraction coupling. So if you look here, let's just take a look here. What do they have in the brackets? They're saying you have inward calcium, inward calcium, and there is a outflow of potassium. So inward calcium, outflow potassium, this basically cancels out each other. So you are going into the plateau phase because one current is going in, the other one is going out. It cancels out each other, gives you a plateau right here. So you can see how calcium is coming in, but you have outward still the outward potassium channel did not close, and that is mentioned right here. So calcium influx occurred, one thing. Second thing is your potassium efflux is also occurring in the same time, and that is giving you the plateau. Two things giving you plateau, phase two. Two things, phase two, plateau, right? Now the next thing is it's about your phase three. So let's look at that. In phase three, what do we have? In phase three, we have the rapid repolarization. If you look here, this is phase three, and this is rapid repolarization, right? That rapid repolarization is a massive potassium efflux due to opening of voltage gated so slow delayed rectifier potassium channels and closure of the voltage gated calcium channels. So what are they trying to say here? They're saying in simple words that you have massive potassium efflux. So a lot of potassium is just going to go out. One thing. On top of that, uh, you have closure of the same calcium channels. So calcium channels are just closed. So all you have is just potassium going out. When potassium goes out, you are going into repolarization. Excuse me. And that's the phase three. Now let's look at phase four. And we will for sure overview it once we are done with the details, the minute details here. So phase four, let's change color here. Phase four is resting potential, which is there is a high potassium permeability through your potassium channels. So this is a resting membrane potential in which you have just there is more permeability for potassium than any other channel or than any other thing. So, and one of the things that you will see on other things that there's a graph of the same way how this is, but it just tells you. Let's just draw that graph here. So let's just say we have ions conductivity. So what ion conductivity we have this, let's say this is in the cell. Let's just draw a line. This is in, like going in the cell, and this is out of cell. Changing color. So we have in the first phase, we had the sodium going in the cell, and that's all about it for the sodium. Then we had a potassium at the same time when the sodium was going in. The potassium is the one which, so potassium is like open all the time. The channels are open. They're only going to close when you are going again into the repolarization state. So this is your potassium channel conductivity. If you see, it's going out of cell most of the time throughout the action potential. And the last, and this was, let me put it this way, this is sodium. And the last thing is about calcium, how the calcium conductivity occurs. That's just, it goes in the cell and comes back out. I mean, it just goes in the cell at this time, and that's all. And this is going to be your calcium. So this is another graph that you might see, and this is same thing as written here. If you correlate, it's the same thing. But yes, that's what we have. So phase four, we did talk about it as a resting potential in which the potassium has a permeability, high permeability through the potassium channels. Okay, what else we might have? So let's just review this, or actually let's read this first, and then we will review it once we're done with this one. So in contrast to skeletal muscle, what's the difference between your myocardium, versus your skeletal muscles. So you have a couple points here. 1, 2, 3. The first point is cardiac muscle action potential has a plateau due to calcium influx and potassium efflux. So plateau, phase 2, plateau, two ions is only going to be seen in your cardiac muscles, nowhere else. So cardiac muscle contraction requires calcium influx from the extracellular matrix to induce, or extracellular fluid to induce calcium release from sarcoplasmic reticulum. All they're trying to say is calcium induced calcium release, and what that is, when the calcium goes in, it induces the calcium release from sarcoplasmic reticulum, in which there is a stored calcium. Okay, and that just it's called calcium induced, meaning calcium induces calcium release. That is only done here as well in the myocardial muscle. The last thing is the cardiac myocytes are electrically coupled to each other by gap junctions, because if you recall, it's all or none law. All or none law, meaning either all will contract or none will contract, is due to the fact that we have gap junctions between them. Okay, so that's the difference we have in the myocardial contractions. Um, so now let's just recall this, and then we look at what we have. More important things, one more thing here with high yield is all about your effective refractory period, high yield. What is effective refractory period? Let's just erase a little bit of these things here. Effective refractory period is just that you have so there are two things, right? Absolute, which is not mentioned here. The two things. One is absolute refractory period and effective refractory period. So let's just also draw absolute. So if you let me do this, erase this. So this is an action potential, right? And it finishes right here, right? So, or you can just say this is an action potential which finishes almost here. So if you go a little higher in this, and you said this part, which you don't have the whole repolarization did not occur, this is your absolute. Oh, it's gonna be too much jumbled up. So this is gonna be your absolute refractory period. Absolute refractory period. What is absolute refractory period now? Well, it is there is going to be no action potential that can be generated at this point, meaning there is no action potential can be generated regardless of inward current. So regardless of what you have, you cannot, regardless if your sodium channel is open at this time, or regardless of any channel opening or sodium channel opening, you cannot generate another action potential, and it is due to the fact that there's inactivation closed sodium channels, okay, that can be reactivated, and this is called absolute refractory period. Another thing we have is called relative refractory period. The relative refractory period is the action potential can be generated for this one. Let's say this relative refractory period. So action potential can be generated, because now what you have is can be regenerated if the inward current is greater than the outward current. Okay, so it can be generated. It's just the way it is. Absolute means absolute. You already know absolute means absolute, right? So in absolute, no action potential can take place. But in relative or effective, the action potential can take place if and only if you have the outward current equals the inward current, or greater. The inward current is greater than the outward current. Okay. What else we might have here? Okay, so now let's look at one more thing about IRK. Let's just write it here. So if you see here, instead of writing normal potassium channel, they have mentioned delayed rectifier. Massive potassium efflux due to opening of voltage gated slow delayed rectifier potassium channel. So what is this thing? So here what we have is basically uh, inward rectifier, meaning IK1. They're open at rest. So when they're resting, they're open, and they will close when they're depolarized. When you have a depolarization, okay. And this is the fact that in your phase 4, what you really have is high potassium permeability. You ask how? How do you have high potassium permeability to potassium channel? Because you're not depolarized, right? And you are just at rest. So at your rest, you're open. These channels, inward rectifier potassium channels, they're open at resting potential. Let me do this. At resting potential, they're open. So when they are open, at resting potential, they're resting and they're open. When they're open, potassium can easily high permeability. There's easy high permeability of that potassium through the potassium channels. And which channel they're talking about? Inward rectifier channel, IK1. Okay, so now let's just recall the whole thing. What do we have? Okay, recalling. Okay, what do we have? Simple thing. This is your myocardial action potential. Myocardial action potential is the fast response action potential, and it has a phase 0. Phase 0 is all about your depolarization due to sodium channel opening. Then you have phase 1, which is all about repolarization due to the fact that you close your potassium, open your close your sodium and open your potassium channels. Phase 2 is about plateau, in which calcium is coming in but potassium is going out. That plateaus the whole thing. And phase 3 is all about your potassium going out from the cell, and that is due to the fact that you have opening of the delayed rectifier, and these delayed rectifier will stay open until you go again into depolarization. So in resting membrane potential, because delayed rectifiers are open, your potassium permeability is there, and your potassium is just permeable. It's not going to close till you again go into repolarization, in which case now there's a closure and there's specific opening of the other channels of the potassium, not the rectifier, not the uh, rectifier, inward rectifier IK1. Okay, so that is what we have for myocardial action potential. Now let's look at the second thing, which is called slow response. Slow response one, or your pacemaker. I mean, it's contrary to thinking, right? Slow response is the pacemaker. Yeah, because they are the pacemakers. Which are the pacemakers? The SA and AV nodes. So specifically, the pacemaker action potential are coming from SA and AV node. Bundle of His Purkinje was all about the top one right here. The myocardial action potential is the even Purkinje, the bundle of His, the myocardium itself, the atria, ventricle, everything is normal myocardial action potential. Pacemakers or specific SNAV node. So key difference from the ventricle action potentials include there is a phase 0, which is an upward upstroke. If you look at phase 0, here's the phase 0. Phase 0 is all about upstroke. Phase 0 is all about the upstroke. Is why did this happen? Because you have opening of the opening of the voltage gated calcium channels. So calcium channels open, and which type of calcium channels? We're specifically looking at all type of calcium channels here. Fast voltage gated sodium channels are permanently inactivated because of the less negativity resting potential of these cells. So sodium channels in phase 0 are permanently inactivated. Why? Because of less negative resting potential. So let's look at less negative. What are we trying to say here? So we are saying in in your myocardial action potential, the resting membrane potential is negative 85, high yield. But in your pacemaker action potential, the membrane potential is about negative 60. So exactly what they're trying to say in this point is fast gated sodium channels are permanently inactivated. Why? Because there's a less negativity. I mean, negative 85 is here. Here you would have the activation of sodium channels, but you're already in more positivity than negative 85. You're at negative 60, man. So what's going to happen is these channels are going to be permanently inactivated. So because of less negative resting membrane potential, results in slow conduction velocity that is used by AV node to prolong the transmission from the atria to ventricles. Okay, so what's the benefit of that? The benefit is that you will have a slow conducting velocity, meaning if you look at the time per second, you have just, let me go a little down here. You can see, okay, here. If you look at the time, it starts here. There is no other phase other than phase 0 at this point till about this point, right? So you have a slow conduction velocity that is specifically very important to be used in the AV node to prolong the transmission from atria to ventricles. And type phase 2 and 1 and 2 are absent. So all you have is phase 0 and all you have is phase 3 and phase 4. So let's look at phase 3. Phase 3 is repolarization. So if you look here again, it's a repolarization, and this was depolarization, right? So phase 3 is repolarization, which is due to the fact that you're inactivating the calcium channels. That increases the activation of potassium, and there is an activation of potassium channel causing potassium efflux. So you're inactivating calcium, but you're activating potassium channels that causes efflux of potassium, and there's influx of calcium here in phase 0. So what is lastly phase 4? What is phase 4? So let's talk about that. Phase 4 is a slow, spontaneous diastolic depolarization. It is due to IF, funny current. Funny current, important. IF channels, they're responsible for slow mixed sodium inward. One thing is sodium. What are IF channels? They're mixed channels. They will allow the sodium inward, potassium outward current. Different from the sodium channels, inward sodium channel in phase 0 of ventricular action potential accounts for, and why is this phase 4 IF current important? Because it accounts for automaticity. Or automaticity, what is this thing? It is ability. Let's see the definition of this thing. Automaticity. Or automaticity is the ability to depolarize without the external influence, meaning your cells are able to regenerate action potential of their own. Within automaticity is seen in where? SA node and AV node. The slope of the phase 4 in SA and a SA node determines the heart rate. So the slope determines slope of phase 4, meaning let's just look at here. The slope, right? It determines the heart rate. Acetylcholine adenosine decreases the decreases the rate of diastolic depolarization and decreases heart rate, while catecholamines would increase the depolarization and increase the heart rate. Sympathetic stimulation increases the chance that IF channels are open, thus increase in heart rate. So you already know this thing is simple. The acetylcholine is going to decrease heart rate. Catecholamines will increase the heart rate. But the thing is, the much important thing that you have to know is about the slope of phase 4. The slope of phase 4 determines the heart rate, high yield. Okay. So now let's just look at the ion things here. What do we have? So somewhat similar to the graph that we made above. Here what we're going to do is we're going to have let's say just write it down here. So this is coming into the cell, intracellular, and this will be going out of the cell, so extracellular, let's say. Okay, so in phase 4, what do we have? We have the funny current we talked about, right? In phase 4 we have the funny current, IF. IF as mentioned here. Let's just zoom in. IF. What is IF doing? Well, IF is, we said that there is inward of potassium, there's inward of sodium, so let's just say inward sodium, and outward potassium, and outward potassium. Okay, so let's look at here. So in the phase 4, we have these IF channels. What's going to happen is you will have inward sodium, right? Now what's going to happen, and you on top of that you have outward potassium that's there. But what about this calcium, ICA T-type? So ICA T-type of calcium channels in here, we are at the level of -60. The membrane is depolarized at -60 at resting membrane potential, right? So this IF channel will allow for the repolarization to go into, it will depolarize till about 50, okay? And at this point, what's going to happen is your calcium channels, T-type calcium channels, will open. Let's change the color here. T-type calcium channels will open, and the calcium will influx through the T-type calcium channels. There's going to be influx of calcium, and that will depolarize the channel to about -40 from here to this point. So as soon as you touch -40, now your calcium channel, which calcium channel? Now your calcium L-type calcium channel will open. And why is that important? Because if we will see how calcium channels, there are specific targets of either the L-type calcium channels, T-type calcium channels, specific targets are there. And this is very high yield because some drugs that just target the L-type calcium channels. And you know that when we target the L-type calcium channel, we're specifically looking at phase 0, but if you target the T-type calcium channels, you're still in phase 4, right? And you're trying to not, you will inhibit this phase, which was going to put the cell back into -40 action membrane potential, but that would have caused your activation of L-type calcium channel. So if you inhibit this thing, right, this L-type calcium channel, then the cell will not depolarize. Or if you inhibit this thing, again, cell will not depolarize, because you need a threshold of -40 for the L-type calcium channel to start working. Okay, so that is why it is important. So let me just quickly do a simple thing here. So here what we have is inward of your sodium, outward potassium, and again you have inward of calcium, but another channel called T-type, mentioned here, T-type. Okay, but here all they want is till -50, and at -40, who's gonna get activated? Let's change color. You will have activation of your calcium influx. Again, there's an influx of calcium through which channels? L-type, mentioned right here, L-type, and they will lead to phase 0, and phase 0 will occur, and this is all there's going to be influx of calcium. There's a stop rate of influx of calcium at that point, and there's just efflux of potassium, and it will lead to repolarization, again going towards about -60 membrane potential, and you are back in the resting membrane potential. And that is what we all have. Simple. So Let's just recall the whole thing and move it on to the next. So what do we talk about here? Simple thing. We're looking at in the pacemaker action potential, we're looking at SA and AV node. We're talking about phase 0. All we are saying is phase 0 calcium influx, nothing else. There is no phase 1 or 2, so there's phase 3. For phase 3, we are saying okay, only efflux of potassium, and then you have phase 4. Phase 4 is the funny current IF channels, which are doing a couple of things, which are putting the sodium inside the channel, but also there is a potassium outward current, so taking out the potassium. And on top of that, you have, other than the IF channels mentioned here, you also have calcium T cell type. All their job is to make sure that the cell goes toward negative 40 membrane potential. As soon as the membrane potential goes to negative 40, the L type calcium channels get activated and the depolarization occurs. Excuse me. And that's all we have for slow response action potential. Some other important points. Let's just read this. It's about IF again, because IF is a high yield thing. IF current, funny current, right? So IF is a funny current. IF depolarizes by inward of sodium and outward of potassium to approximate negative 40. At negative 40, the threshold calcium channel open, and those calcium channel T types will cause negative 40 is the L type, which cause influx of the calcium occurs, right? IF channels turn on by repolarization, and yeah, that's pretty much it. Now let's talk about a couple terminologies. Okay, one of the thing is called inotropy. What is inotropy? Inotropy is all about contractility. Contractility. What is chronotropy? Chronotropy is all about your heart rate. And what is dromotropy? Well, dromotropy is all about conduction velocity. So inotropy is contractility, chronotropy heart rate, and dromotropy is about conduction velocity. This is some just definitions of some things. Okay, one thing here, we did talk about this thing, which is called calcium-induced calcium release in the in the cardiac muscle, right? So what's really happening in the opposite in the skeletal muscle? So in contrast, skeletal muscles, they don't require calcium influx, and if they don't require calcium influx from the extracellular fluid to interact with their ryanodine receptors, instead what they want is, the skeletal muscles, the action potential directly. So instead you in skeletal muscle, action potential directly stimulates your ryanodine receptor RYR channels, okay, to release the calcium from sarcoplasmic reticulum. And that's important to this concept, which is calcium-induced calcium release, which is in this cardiac muscle, but in skeletal muscle, that action potential directly stimulates the ryanodine, again causes release of calcium from the sarcoplasmic reticulum. Okay, so that's the difference, and that's all for this thing. Moving on with the ECG.